Thank you. Okay, we're good. So welcome everybody to Winter 2018. This is the third buzz session for me for this term. I'd like you to just go and introduce yourself briefly and introduce your topic and just, sort of tell us where you're going, and then we're going to get into reviewing gaps and sort of kind of organizing people's ramps so that they feel like they have an idea where they're going. Once we have an idea where we're going, then we'll also start talking about measures. So Adam, you're on my far left. You want to go first?
Sure. Can you hear me?
Yep.
Okay. I'm Adam Richardson. I work in a large urban emergency department, one of the highest acuity emergency departments in the country. And my project is about increasing access to take-home naloxone kits and the relevant education to at-risk patients and potentially even their family members.
Great. And Karen?
Okay, so I work in a birth center in a small city, and we see about 60% Medicaid patients. My topic is postpartum depression, screening, treatment, and follow-up. And we have a real gap in our community with resources. And so I think that's really resources and knowledge base of the providers. And so that's really probably the biggest gap.
Great, thank you. And last but not least, Carrie.
Hi, I am doing my project topic on depression screening and follow-up.
And where are you, Carrie?
Sorry, I'm in over the pond from Seattle in Bremerton, very small town. Yeah.
All right. Well, wonderful. I'm not ignoring you guys. I'm just trying to keep an eye and see if Jeanette is trying to reach us, because I find it very strange. I literally hung up with her half an hour ago and she's not here. So I'm just going to keep trekking. So what I'd like to do today is go over the buzz or the gaps with you, see if we're starting to kind of come up with a rationale, a framework that you're going to use, and also then what your ramps are going to be like, and then we can sort of set you free and start talking about measures. So the way we did this the other night, they worked really well. There's only 3 of you, but that's okay. Is somebody sort of talked about their team, what they have on their gap analysis at the team. Somebody else talked about their patient. Somebody else talked about their ramp C and or D kind of stuff that they have. And then we'll start piecing it all together. Does that sound like it works for you, or there's only 3 of you, so if you each want to look at all of yours, we could do that, sort of. You good with the first method?
Yes.
Yes.
Okay. Who likes their team? Let's talk about somebody who wants to share their gap analysis for their team.
I have a lot of problems with my team.
That's going to come.
Yes.
Karen, did you say you wanted to share that?
Sure. I'll share my gap analysis.
Do you know how to do that on this?
Oh, like just show you like a
So if you squiggle your cursor around, you're going to see up on the top left a little green arrow.
Mm-hmm. Yeah.
And then if you click on that, it says share.
Uh-huh.
Share your whole screen.
Okay.
And then you want to bring up in front of you whatever your gap analysis and show us that. If you're looking at it, we will be looking at it, but you haven't shared yet.
Okay.
You aren't there yet because the screen will turn it'll look differently. There we go.
Okay, good. Now I just need to find it.
Yeah, now pull up your other one.
Mm-hmm. Let's see. You want the actual gap analysis? Is that
I do.
Okay. All right. Hold on a second. I'm sorry.
That's okay.
It's going to take me a minute. Do you want to let someone else share first?
Does somebody else have their whatever ramp they want to share?
I actually did a little very short PowerPoint presentation that kind of presented everything on mine. If you guys wanted to go through that, or we can do it the way.
I just want to see your gap.
Okay.
Because more than you presenting, I want to see us working
Okay.
on it as a team. Let's
I've
see.
got my gap
Oh.
analysis tool pulled up
All
now.
right, Karen. All right, let's scroll it up a little, Karen, so we can see all of your A.
Okay. Hold on. Yeah, that's all of my A. Do you see it?
Yep. Can you make it a little bigger?
Yep. Well,
No, that's okay. Just make it bigger, and then we'll start with the first row.
okay. Okay.
Okay, now scroll up so we can see it. There we go. That's perfect. Okay, so let's just look at column 1 and column 2 of Karen's teamwork part. What do we like about just looking at column 1 and column 2? What's great?
Oh my gosh.
I think the daily huddles and then the monthly, more in-depth meetings will probably work well.
So she's got best practice strategies, doesn't she? She's got options for herself. She's said, okay, teamwork is effective communication, which is one piece of teamwork, and she's cited it. So she's not just pulling this out of the air. She said, establish record systems so they can record things and share client information. She's recited that one. Daily huddles, and this Schottenfeld, we're going to have to love this person because she cited them for all of them, and monthly or bi-monthly interdisciplinary meetings. So she's given 3 best strategies and she cited them. We know that she got these from somewhere, right? Okay.
Yes.
So Karen, tell us a little bit about how your practice differs from best strategies.
Okay, there are 3 midwives in the practice. It's a midwifery-run birth center. No physician provider. We spend 1 week in clinic every 3rd week, 1 week as second call, and 1 week as first call. So the clients are seeing all the midwives. It's truly a team approach, but there's no method of communication in place for the plan of care for each patient. And that to me is the huge problem, because the only connecting point is the RN, who is there every week in clinic.
Right. Okay. Great. And then you don't use any type of huddle.
Not anything formal.
Okay.
I'm pretty good about tackling the RN and asking her what's going on with each of the clients we're going to see that day, but there's no formal team huddles used.
Okay. And you said yes, yes, but no to monthly meetings.
That's correct. The site, what do you call our sponsor, did not want to go with monthly or bi-monthly midwifery office nurse interdisciplinary meetings. She felt that it would be more productive to have the midwife going off clinic to call the midwife coming on clinic with anything that has changed in the clients.
So you guys are an accredited birth center?
Yes.
And you don't have, do you guys do chart audits?
Yes.
But you don't meet about it. You just turn them into somebody.
And we turn them into the RN. I haven't been there but since July, and I've only come full-time this week, unexpectedly full-time this week. So I've never had a meeting where we've reviewed the chart audits.
Okay. So these are great strategies. You think you can do 2 of them. I think it's going to be really interesting to do a project where you never meet, but you're going to have to figure that out. So
Right.
What she has is she has identified not just what teamwork, but she's identified that communication is a huge issue. And I, just listening to you, I would say I agree with you.
Mm-hmm.
She's come up with some best strategies and how that might happen. And so she's really got process of huddles and outcome of communication. She's really got a great ramp, even though she has 3 sections there. Does everybody see that? So you're thinking about, how am I going to get this done? And then what is the outcome if I do get this done? So that's when we start to get into measures. But she's got 3 best practices here that are very, very good. basically they're meetings, team meetings, and it within that team meeting, the monthly meeting or the bi-monthly meeting or the huddle, her outcome is going to be to communicate. So that established records, that might be it. Let's put that on the side burner, because that might be its own dang ramp. That's a biggie.
Yeah, it's really just it's a part of our chart that's already there, which is, and it pops up as in red. So problem, action, and that's not being utilized. And so when you see
so it's your problem list, but it's not being utilized.
Yes, right.
Oh my God, I couldn't live without my problem list.
I know. This is a problem, especially when you only take the clinic every third week. And you know, to their defense, they are a birth center that probably 6 months ago was doing 4 deliveries a month with 2 midwives, and now they're doing about 12 deliveries a month with 3 midwives. So
yeah, so they've tripled.
Yeah.
Yeah. You're gonna swip them into shape there.
Yeah.
All right. So I want you to hold. I think your teamwork is great. I think you've got some great ideas with huddles. I think you're going to have to figure out how you may have to win her over with kindness, but you're going to have some meetings somewhere and somehow. Bring lunch. I don't care. Take them out to dinner. I don't care. But you're going to have to figure it out somehow in some way. But huddles are a great place to start with. But I want you to hold on to that record system, because I want to make sure we don't lose that one.
Mm-hmm.
So one of the things that's really important here is teams are they are the basis of everything that we do. So if you don't spend some time focusing on the outcome of teamwork, some aspect of teamwork, it can be teamwork in general, engagement, communication, all the pieces that make up teamwork, leadership, there's a whole slew of things that you could think about. If you don't make that part of your focus for your outcome, you will focus on the task of having the team do something versus building them as a team. Does that make sense to everybody?
Yeah.
It is. I cannot tell you, I wish you could see me jump up and down how important that is, because all the projects who don't do that really, really struggle. So if you don't want your project to struggle any more than it has to, you will take to heart what I'm saying. All right, Karen, so that is great. I see a very clear A ramp for you, but I want you to hold on to that problem list. I don't want to let that go. Who would like to tackle B, their ramp B, what you have?
I can.
Okay, go ahead.
Okay.
And just while we're on it, Adam, did you have anything else really exciting on your A ramp?
No, not really exciting.
Okay, all right. Anything brilliant that we needed to share?
No brilliance at all.
Common vision, I love that though.
Yeah, that was brilliant.
Yep, and routinely remind staff via huddles. Okay, great. So huddles, emails, again, good. Okay, so your B ramp. Talk to us about your B ramp.
So my B ramp is patient engagement and basically educating the patients who are at risk of overdose. Well, that they are at risk, because it's more than just heroin users. It's I have a whole tool, but there's a list of who is at risk, and it's even for people who don't abuse opiates. If you have any renal dysfunction, any liver dysfunction, even an acute infection, poorly controlled asthma, and you're prescribed, Percocet for, say, your broken wrist, you are at risk for overdose. So it's not just heroin addicts. So that's one part of the patient education tool. Just helping people realize that they're at risk who may not realize it. And also just helping them understand that, so we have an SBIRT team. I know SBIRT gets thrown around a lot, and Dr. Jolles was getting confused by me by the way I was using it, because we actually have an SBIRT team of peer recovery coaches. So
Uh-huh.
everyone who's flagged by the triage process as at risk is seen by a peer recovery coach from our SBIRT team.
Okay.
And 100% of them are offered placement in treatment that day.
Great.
100% of the ones that SBIRT gets to.
Where
Go ahead.
are you? Where are you?
University of Maryland Shock Trauma.
Dang. Okay.
Yeah, it's a really, the coolest thing about the program is that the NP that oversees SBIRT is also my boss. So we fall under the same umbrella, which is nice for communication on this project.
Okay. So tell us about your tool or what, or your things.
So I'll just pull them up. So this is ramp B. So far, I have, can you still see my screen?
Yep.
Okay. So for ramp B, I have this engagement survey that kind of asks, like, did you realize that you were at higher risk? If we gave you a prescription for take-home Narcan, would you fill it? Would you allow us to give you some brief instruction? And then my ramp D is providing a kind of different educational thing to their family member if that exists. So this kind of also asks permission for that.
Okay,
and
so
then,
let's stop for just a minute. If this is your ramp B, are you doing a screening for who's at risk for overdose?
So the one thing that my facility does really well is they screen who's at risk. I mean, that happens in triage pretty effectively.
Okay. Okay.
So
you're getting that population, that process
That's
is
correct.
being done well, and that's coming to you.
That's exactly right.
So your ramp B is going to be just for the people who are high risk?
That's correct.
Okay, so you are getting this, and then what? So is this? So a shared decision-making tool has to have a. This is kind of. I think of this almost like a screening.
Yeah.
You know
I'm
what I mean?
I'm trying to get them to participate in taking take-home naloxone, and I mean, that's shared decision making. I guess, like, how can I make this a shared decision making tool?
So let's talk about that. That's a great thing to talk about.
Okay.
Go back to your ramp B. Let's see your ramp B. Let's look at everything.
On the gap or on that?
Yeah, on the gap. Sorry.
Okay.
Okay, so you have patient that should be educated on factors that make them at higher risk. And then you have at-risk patients should be educated on how to take home naloxone is available and how it works. And is there a number 3?
Yes.
And should be educated on how to properly and effectively use take-home naloxone to reverse a life-threatening thing. Patient will be given a packet that surveys their comfort in administering naloxone. Okay, so it's you have 3 different things on this naloxone take-home thing, and you want to educate patients on it.
Yes.
So Carrie and Karen, tell me, it's the end of the day, man. I got to tell you, it's been a long week. I'm surprised I can say your names. Tell me how you would define, give me 1 or 2 words each that for you describes what a shared decision making, what are qualities of shared decision making?
I think that has to be interactive.
It's
Interactive with, I'm sorry, Carrie, interactive with who?
With whoever's administering it. I mean, it should be ideally the provider, but it could also be clinic staff. It's whoever's providing that education. Yes.
Somebody and the patient. Okay. And then Karen?
It's shared decision making, but you need to provide the patient with a tool in order to help them make evidence-based decisions complete with risk and benefit.
Okay. And so now, Adam, I'm going to ask you, what is an evidence, how do we define the triad of what an evidence-based practice, when we discuss that with our patients? What is the triad? I think I'm asking that wrong, but hopefully you know what I'm talking about.
Yeah. It's
Karen and Carrie, help them out.
So it's the patient's beliefs, and then it's the evidence-based medicine, and then the clinician experience coming together, and it finds that
Right.
sweet spot in the middle that's patient-centered decision making.
Okay. So now, Adam, think about the tool that you just showed us that asked all of those questions.
Okay.
Does it give them some information? Does it educate them in the process of that whole thing?
I think so.
Go back to it again.
The
The questionnaire that you had for your
Okay, so I have
BNR?
I have the survey, and then I have like an education piece too.
So the survey is your outcome.
So this is the second part of the RAMP-B tool.
Okay, where's the first part? Oh, now you have something that I like already. I can tell.
Okay. So I have this survey, and then I have that thing that I briefly just showed you.
Let me see the thing that you briefly showed us.
Okay.
So to me, a shared decision making should be exactly what Carrie and Karen said. It should be interactive. It never should be, and at the doctoral level, never will be acceptable to be like, here you go, read this, tell me what you think. That's like the lowest. It's good. It's better than nothing, but it's really, really, really low level. Okay? So it should be something that if you're going to ask them questions or invite them to participate with you, you're the expert here. You are the person responsible for getting and finding and sharing the best evidence. So it should share best evidence. Naloxone is good for blah, 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 blah. It's found to be helpful in you're at high risk because you took this survey, and you're at high risk for overdose because of blah, 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 blah. Do you agree? Are you interested in this preference?
Mm-hmm.
And okay, now let me show you. And then let's come to a decision together. What do you want to do? Does that make sense?
Yeah, that does make sense. I had Dr. Jollis was saying that like a teach back part would be.
Yep.
So that's what I don't know if you can see in bold here. I just kind of summarize RAMP-B.
Okay.
And tell me if you think it.
So that is great. So a lot of education, but instead of just handing them a pamphlet, you're going to go up that Bloom's taxonomy, right? You're going to start with educating them. They're going to understand it. Then they're going to spit it back to you, and then maybe show you how to use it or whatever, so that you could do role playing, you could do teach back, all those kind of things.
Right. And I have in here that it addresses that. I mean, they're most likely that they're going to save somebody else with this naloxone kit, or they're going to teach someone how to save themselves. So I kind of go through that as well, and have them teach back that.
Beautiful.
Like how to explain what I just taught you to a layman, because you're going to be teaching it to your other addict friend. You know what I mean?
Right. Okay, that sounds great. And so you've got some citations there, how education is so important. Can I see the rest? I want to see the other 3 columns there. Yep.
Okay.
So patients that are flagged as high risk. So but you said that process happens really well right now, and you've got some statistics on the percentages and all that?
Yes.
Okay, great. Because that's if that's where you guys know your system. You know what happens in your system and which possible. I think of this as in the old days when I first took a computer class back in high school, a million trillion years ago. We had to learn the language, and for me that was really hard because I'm an intuitive thinker. And so for pulling each piece apart to learn each little thing, and if it said yes, you went left, if it said no, you went right, that was really hard for me. And that's sort of what we're doing here. If you know that screening gets done really well, and we don't want to just say really well, but we've actually looked at it, and you pull some stats on it, and it's upper 90 percentile, then you're not going to get a lot from doing that. That's already be doing well. We don't want to fix things that are already done. So you can take that information, okay, here's this plop of people who now are high risk, and this is what they need. They need this naloxone teaching as well as the kit. So that's a great shared decision-making opportunity. And that's what when I came to this I see that you have those patients flagged as high risk. So that's already done. You know your system, and that's already done well.
Yes.
Whether this process, yes, this best practice is already in place. Good. Should be educated on how to take home naloxone. Informal survey indicate that this is being done, but without a standardized process. Cha-ching! Bingo, right? These are the words you're looking for.
Right.
Stakeholders agree, another word that we're looking for. Okay, scroll up a little bit, I can't see. Yep. And let's look at number 3. Educated on how to properly and effectively use it, and the stakeholders agree, and you've done some surveying. Great. Okay, so he's got a great shared decision-making tool. And so the process, what is the process for this ramp going to be for you, Adam?
Well, I guess maybe I need to rethink how I word it to make it more interactive shared decision-making. But basically, surveying to make sure that they understand that they are at risk, asking if they would be interested in a prescription for take-home naloxone and education on how to use it, and then asking them to teach back to me as if I was one of their layman friends why I may be at risk, what an overdose looks like, and what to do about it.
Okay, I'm going to throw in one thing here. Carrie
Okay.
and Karen, if I were to, you guys, family nurse practitioner and midwife, I'm just trying to think of a common scenario. Let's say in depression, you came to me, I know you're depressed, and I say to you, are you interested in medications? My first thought I'm in a birth center. People generally don't want to do medications. They like their hoopty-doopty stuff. They're going to say no. But if I was to come to them and say, you know, your score on this EPDS is 17. I've been talking to you for a few minutes, and I do feel you're at high risk for depression. I'm a little worried about you postpartum. I always, of course, counsel them on, I'd like you to get to counseling. But I do think you're a good candidate for medications because of blah, 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 blah. In my experience, blah, 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 blah. Now I'm going to ask you, are you interested in taking medication or me prescribing medications? So I would only say that to you, Adam, is that I would ask them that after you've done a little bit of sharing and teaching with them. Mm-hmm. I think you're going to get a better response from, I mean, you know your population. That's just, if you want them to do something that they might not want to do, you have to kind of lead them there.
No, that makes perfect sense. I'm just trying to think how I can incorporate that into that survey. I guess I could just add some of the education at the top. Go ahead.
So I was really struggling with that too. And then I watched that Espert video that was talking about drinking and alcohol, and they had this nice little graphic that was a triangle that kind of showed the risk of the population. Like 90% of the people that come in here don't drink as much as you do. Of course, they said it nicer, but I'm actually trying to incorporate a graphic into mine so that I'm not just showing them a number, but I'm actually showing them like a graphic that's easy to understand of like, you are low, moderate, high risk, and, you know, low is like green, middle is yellow, and red is like high risk. So it's like, I'm trying to prove with a graphic, like, you are in this risk and I'm concerned about you. How do you feel about that? So I get there, you know, that I don't know if that would be something that might be beneficial.
Yeah, no, that makes sense. I
just felt like it was an easy way to break it down.
Yeah. And I have a bunch of that stuff in all the tools and lit reviews I did. So
yeah. And sometimes it's just how you rearrange them. You know, it's just looking at you know, rearranging, taking the pieces from one, putting it on the other. If you have a toolkit, because of course substance abuse is such a hot topic and there's been so much done, you may find something that's got it all ready for you, you know. Then it's like, okay, this is too long or too short or whatever. But don't be afraid to cut and paste.
Okay.
Yeah, I Googled like Espert toolkit for like, I think it was just depression, but there was one that was for use, like narcotic use and stuff like that. Was like I found one from Vermont actually, which is weird because I'm from there. That was actually really good. So you might look at that one too. They had like 5 different categories, and I was kind of impressed with what they had. So it's like from the state. Yeah.
Okay.
All right. How are you feeling about your B ramp, Adam? You feel okay?
Yeah, I think I feel okay. Does it seem like
I know what I
off to a good start?
Yes, no, absolutely. But when I asked you what your process was, you started telling me about your survey. A process is something of how you're going to do it. A survey is how you evaluate it.
Okay.
So when I asked you what your process is, when you have a tool, how many of you have read that have gotten up to the measures reading? And
I
then,
have.
I have.
Okay, so when you have a tool, how do you measure the process of that tool? You have a shared decision-making tool. What is the process measure going to be for using the tool?
Well, how many at-risk patients, basically divided by how many at-risk patients identified, divided by how many were provided the information and then surveyed.
Okay, so if 10 people were identified and 5 people were surveyed, what is that equal?
50%.
Right, but it's actually 10 over 5 doesn't equal 50%.
Oh.
So that's why you're exactly right. It's 50%. You know it, but you've got to be able to write it out in words. So that's why I always use the number 10. And the
Okay.
example that I often give is exactly what you do. 10 people came in and were high risk. And it was a busy day, so I only got the tool to 5 of them. 5 people used the tool. So 5 people used the tool, the part over the whole. 5 people used it, 10 people were total. So the process is did the tool get used? Because you can't know anything until you find out if they actually used the tool. Does that make sense?
Right. Yes.
And then your outcome is probably going to be, it could be as simple as, they use the tool, they come to a decision. And hopefully it's the evidence-based decision, right?
Mm-hmm.
But I would encourage you, because I just got off the phone with a student, so this is something that's sort of hot on my brain. She is also using a shared decision-making tool, and they come to a decision. But she's found out after 2 cycles, well, they come to a decision doesn't really help me. They either say yes or no.
Okay.
But she put 3 questions at the bottom of hers also, and it was something like, do you feel like you were listened to? Do you feel like you were able to ask questions? And she had one other one. So she not only came to a decision, but now after 2 cycles, she's like, you know what, Dr. Butler, this really isn't, the yes, no isn't answering my question. But these 3 questions, if she gave them a 0 and a 1, she could take an average score of those 3 questions, and it would probably, what it's showing is that as the scores go up, that your work with the tool is getting better. You know what I mean?
Yeah.
So you're not only finding they're coming to a decision, but they're feeling like their voice, you're really getting to the heart of shared decision making and finding out if they feel truly that you were doing shared decision making and engaging them.
Okay.
Does that make sense?
Yeah, it does. It does.
For everybody, you guys, did you all hear that?
Yes.
Okay. Carrie, are you up?
Yes.
You want to do C or D?
I can do either one because I'm
Do
doing
you have
both.
a C?
I do, and I have a D.
Okay. Let's see your C, because that'll make more sense if we kind of go in order. So
Okay.
Karen, you're doing depression. Carrie's doing depression. And Adam, you're doing your opioid naloxone.
Correct.
And Adam, just tell me what you're thinking. Are you going to do an ESPERT? Are you screening people? Or are you doing something different?
My C is it's basically a checklist for the NP to go through. Let me just show it to you real quick.
No, it's okay. I just
Okay.
want to make sure I want to see if we have differences. A checklist is actually kind of a screening, so we'll go to that next.
Okay.
Carrie, we're looking for your C.
Are you able to see it?
Patient engagement, there we are.
So
this
this
is-
is my C.
Okay. So you have lovely best practices here and your citations, and you have 3 best practice strategies, and you're telling us how they differ from your team, your cause and effect, and then will you be able to implement with some rationale, which is great. Okay, so let's see. Her best practice is implement the USPTFS guideline for depression screening and healthcare data effectiveness information set measures. So you're not, okay. So basically she's doing a screening. She's got the PHQ-9 for adults older than 19. And she's got documentation of care following follow-ups and correct diagnoses. Okay. And then how your practice differs. Carrie, why don't you tell us what's going on at your practice?
Okay, so currently at my practice, I actually just got this beautiful graphic from some data analysts that I'm working at that show that my clinic just merged with another clinic. The other clinic is a bit more based on productivity, whereas my clinic is a bit more based off of quality improvement because my clinical operations manager actually is certified through the IHI. He worked with them, and then our VP of quality is a fellow from IHI, so I'm extremely lucky. And they are really excited about this project. So basically what it shows is that our past before we merged, right now only 5% of the providers in the other clinic were doing PHQ-9 screening, and we were only at 26%. So we're not doing really much screening at all. It's not consistent, and we have no idea when we're supposed to be doing it. A lot of the staff doesn't know when they're supposed to be doing it. That's kind of back on my other engagement ramps. So my best practice strategies are to actually implement doing it for all adults older than the age of 19 every year. And we have no standardized workflow. I don't know how much detail you want me to go in on this, but.
Well, just that you're doing, so you have a RAMP C and it's screening. So you're
Yes.
doing a pretty typical SBIRT.
Yes.
So her RAMP C is screening. She's got a framework that she's going to be using. And she's, again, got citations. She's got a tool, the PHQ-9, that she's going to be using. So anytime we have a tool, when we talk about measurements, which is sort of where we're going to talk next, how do we measure the process?
When we have a tool,
Mm-hmm.
by looking at the results of the tool and also seeing if it was used.
So it's the process is the utilization. Was the tool used? That part over the whole. 10 people walked in, 5 people used the tool. So we got to make sure that before we can decide what we're going to do, we have to get the tool used. So that's the process, which is very important. And a typical SBIRT, when you screen people, the outcome is what? Any tool you use, what is the outcome?
That it got
When you're
used.
screening. That's the process. The process is that it gets used. What's the outcome? What
That
happens
everybody
when you
got it.
use this tool?
That it
Carrie-
identified the problem, that it was sensitive and specific.
That it identifies the people that you're trying to screen them for something. Depression, diabetes, checklists, I don't care. You're screening them for the labs that were done, weren't done, yada, yada, yada. You're identifying those people who are what we call positive. They could be positive because they're positive because they have a problem. They have a lack of labs. They have a lack of treatment. They need something from you. We have identified people of need. Okay.
Mm-hmm.
So processes for every tool. The process is, are we using the tool? Utilization, and the outcome is whatever. It's identification of whatever it is we're screening for.
Right. I've
That
actually
makes
kind
sense
of,
for everybody.
yes.
Go ahead, Carrie.
I was just going to say, actually, from doing this gap analysis and kind of talking to my team a little bit, we're actually going to go with the PHQ-2 for screening instead of the PHQ-9 as initial screening. And then based off of whether or not they're positive, they would do the PHQ-9 in the room.
Right. And what does best evidence say?
That it's okay to do that.
Right. So does everybody know what the PHQ-2 is and the PHQ-9? It's just a depression screening. So you start out with 2 questions. If your 2 questions are negative, then you don't need to go to the 9 question.
Oh, I don't have it in here. Darn it.
That's okay.
I had like a pre-visit questionnaire that I made to try and engage the patient on their pre-visit, and I actually just included the PHQ-2 on that pre-visit questionnaire.
Which now, if you're going to do the PHQ-2, you could actually keep it in there. That's a really great point. So we talk about the ramps, A, B, C, and D. First of all, hello, Jeanette. We're glad you're with us. I was sending you mad emails trying to find you.
Hello. I'm sorry. I thought it started at 6.
Nope, 3:15. 3:15 my time, 5:15 your time, or somebody Eastern time. That's okay. We're here.
Okay.
So what you can do, which is possible, is, Carrie, can you pull that tool back up that you just had?
Yes.
You have to be careful of this. What Carrie's done is she's going to be using the PHQ-2, 2 questions, to screen her folks. If her folks screen positive, she's going to be doing this whole engagement tool, just like Adam is. His patients have screened positive somewhere else, so he's skipping that part. Carrie's incorporating that part. you could use the PHQ-2 in this tool as your ramp C. And then if they're positive and they go on to use the rest of the tool, that could be your part B. That could be your B ramp. Does that make sense, Carrie?
Yes. So I actually have that. So here's my updated pre-visit form, and you can see that I actually put the PHQ-2 in here. So I actually already started doing quality improvement on it.
Right. So, but does everybody understand that? Just because it's one piece of paper, you don't have to have a separate piece of paper that screens them and a separate piece of paper that engages them. But you have to be very, 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 very clear in your own brain that this part is my screening and this part is my engagement.
Okay.
I'm going to say that one more time because this is really important. You can have your screening part of your program on a piece of paper with the same piece of paper that's got your engagement piece, if it's engagement only for the people who screen positive. Or maybe it's for everybody. I suppose you could do it both ways. But in your brain, you've got to be able to say, these 2 questions are my screening. This 5 bottom part is my B ramp. You've got to be able to separate out your B and your C, even though it's on one piece of paper. Does everybody get that?
Yes.
Yeah.
Adam, you look not convinced.
No, I think I get it.
Okay. So that's great. So you've got your C ramp that you're going to screen people, and your outcome is you're going to identify the people for Carrie that are depressed. Okay.
Yeah.
This is another great example here of we would never want to now go do something completely different in our D ramp, because I call this ramp a hanging ramp. Now I know Carrie's going to take care of it, but if she didn't, if she was going to go and do patient portal for D, she doesn't know. These folks that we've identified as depressed are now just hanging out there and they're not getting any care. We never want to leave that just hanging. We always want to make sure if we've identified something or we've screened people or we've found labs that we're missing, that we get them the care they need. Make sense to everybody?
Yes.
Okay. And Jeanette, you're late to the party, but we have done, we have looked at everybody's A, B, and C. Would you like to share what you have for D?
Sure. So just I pull it up on my screen?
Sure. And you know how to screen share, Jeanette?
No.
If you just squiggle your little cursor around, you'll see a green arrow in the top left.
Okay.
And then if you click on that and then say, I want to share the entire screen.
Okay.
There you go. And then now just pull up your, whatever you're sharing with us, have it, just pull it up.
So the gap analysis, yeah.
Yep, perfect. Perfect,
So
perfect.
I'm doing an HIV education project, or I'm sorry, a project with HIV positive patients. So, you know, I've kind of been all over the place, but basically landing upon HIV risk counseling, which is a part of a core measure through the national organizations, including HRSA, and then there's other, you know, subsidiaries within that. But so the HIV risk counseling is assessing patients for their risk to transmit HIV to others, and then performing counseling to help patients decrease their risk for transmission. So ramp.
Go ahead. No, go ahead.
So ramp C, I was thinking was, you know, more of my screening, although that differs a little bit from what's on your screen. So basically, you know, I would use a risk assessment tool, but part D then is likely using a right care checklist to be able to follow this core measure, a clinical core measure that's defined by HRSA, the Health and Resource Service Administration, the federal organization. So there's a lot of things that are included within these measures. So it gets it a little muddied, but part of that, one of those is HIV risk counseling. So we really look at HIV medication now more like a prevention for transmission of the virus.
So Jeanette, can you share with us 3 or 4 things that are in that Right Care ramp to get them what they need?
As far as the ramp D, so it would be the actual counseling or the assessment. Is that what?
So the screening is in ramp C, and say these
Yes.
folks come up high risk.
Correct.
So
And-
what are you gonna make sure they get in ramp D? What is the list of things?
Yeah, so it'd be a medical provider that does a brief intervention, and these are evidence-based, that even just a brief intervention from a provider can make a difference in a patient's HIV risk transmission. And then there are longer sessions that occur with the case manager, and we do have those on our team so that they can move forward with a little more in depth in the psychosocial aspects, like their homelessness possibly, or their drug abuse issues. So that includes HIV education and health education. And again, this is some of this, and there's well defined whether that's a provider or a case manager or both. And then STD screening and treatment. Disclosure to your partner. We found that are they telling their partner that they have HIV, and many times, yes, they are hiding that. And then medication adherence and building skills, and then making those referrals finally for their psychosocial problems. So such as substance abuse, referring that off to a counselor.
So she's got a list of 5 or 6 things that she's going to identify. She's going to have people screened with her risk assessment. She'll identify people that need this bundle. They'll come down into some way she's got to track these folks to get them that list of things that needs to be done. Does that make sense? So that her people aren't identified and hanging there. She's bringing them down. In her case, in the typical SBIRT case, she's bringing them down to ramp D. She's identifying in ramp C. She's bringing them down into ramp D, and she's going to actually get them all the care that they need. And she's going to track them to make sure that you got your STD counseling, and you got your labs drawn, and you got your yada yada. So she's taking care of them. Now, can anybody tell me, and Karen, are you also doing a similar SBIRT?
Well, because our screening is very well in place, antenatal and postpartum times, what I'm doing is a intervention, interventions that can be offered, and then looking at the follow-up screening.
Okay. Okay. So, and Adam, you're doing a checklist for C.
Yes. So the checklist is to ensure that providers are ensuring that the SBIRT team did meet with the identified at-risk patients, to check off that the NPs offered take-home naloxone and offered the education piece, and then offered to address education with the family, a different education piece.
So you're still doing a screening. It's just screening with a checklist, right?
I suppose so, yeah.
And then your outcome is what? If they do the screening and they find some of these pieces are missing?
Well, right, to rectify that.
And is that going to happen in ramp C, or is that going to happen in ramp D?
It's going to...
Not sure yet?
The clarification happens in ramp C. Ramp D is the family education when it's possible.
Okay, so it's a completely different thing.
Yes.
Okay, so you're really doing what sounds like a right care. It's kind of like a SBIRT, but you're doing screening with your C, your checklist, and you're making sure that whatever you find, you take care of right then in C.
Yes, that's right.
And then in D, you're doing a family intervention, and you're taking care of the family for the outcome of D.
That's right.
So you are doing a right care.
I'm writing that down.
And Carrie is doing an SBIRT. And Jeanette is really doing an SBIRT with a right care. Carrie's kind of has a right care for her D. Jeanette's has a right care for her D because it's a bundle. It's not just like, you're not just treating them. You're not just giving them medication. You're sort of looking at all these different things. Am I correct with everybody?
Yes.
Yeah, that sounds right.
I'm thinking I'm doing the right care because the screening's already been being done.
Okay, Karen, so let's talk about yours for a second and see what you're doing. Talk to us about your ABCD what you're thinking.
Well, we already talked about A, right, which was the
Right.
team. engagement. I've got shared decision making.
Okay.
And then doing that with some personalization posters, some decision support tools, and
Okay.
use of teach back strategies.
Okay, great. And what about C?
C is develop an integrated care plan for a woman with a mental health problem in pregnancy or postnatal period. So using the ACOG postpartum visit algorithm and plugging into that. Trying to figure out what we can offer for care in that because right now we've got, as I said, it's about 60% Medicaid client population, and there's no clinical network resources for people with Medicaid. So there's no counseling, there's no support groups, there's nothing that we can offer them except for medicine and maybe follow-up phone call.
Okay, so right now you're looking at, you've already identified the people, and what percent of your population is depressed?
Pretty high proportion, actually. We've got a huge suicide rate here in Grand Junction, and mental health issues are a big issue. I don't know what percent of clients are.
So you don't know what you're screening right now very well.
Yes.
But you don't know what your percentage are of those people who screen are positive.
I don't think I looked at that when I did my chart audit. I should have, shouldn't I?
So you're going to want to see if, do you have EHR?
Yes.
So you want to find out if you can pull up the diagnosis. Now, this is two different things, right? Are people being diagnosed with depression? Or are they just being, in the notes, people are talking about depression? But I would want to, the easy way, the cheat way is, and I'm all about little shortcuts, is to have somebody pull up anybody with a diagnosis, an ICD code of depression.
Yeah, I don't know.
You want to find out what your rate of depression is. Now, the reason I'm asking you that is we're going to ask you to collect data twice a week. And so you're going to want to, if you've got a depression rate of 20%, which is probably fairly average, 20 to 30%. If you have an average rate of 20% and you see 10 patients, you're only going to be having in that C ramp 2 people.
Right.
That's low.
Mm-hmm.
So that's something else that everybody has to think about. Sometimes it's nice when you do a screening ramp or a checklist or whatever people are doing, because then you're saying, I'm going to do that to everybody. It's okay to have one ramp. If you want your shared decision-making ramp or it's going to be your treatment ramp for depression, because you know you're only going to get 2 people that are going to be positive. The person I was just on the phone with is doing genetic counseling for prenatals. So she's doing genetic counseling with everybody. She's got a shared decision-making tool for everybody. She's screening everybody for the risk factors. You know, are you over 35? Do you have a family history? Blah, 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 blah. And then it's okay that in her D ramp, only a very few people come into that D ramp, because we all know there's not a high proportion of people who actually have a positive genetic screening. Mm-hmm. So one of the things that you want to think about, Karen in particular, but everybody, is am I hitting my B, C, and D ramp to everybody, or is it just is it a small percentage? It's okay to have one ramp be a small percentage, but you don't want to have your C and your D and possibly your B be 2 people a month, because that's not going to work. And you want to think about that now.
Mm-hmm.
Does that make sense?
Yeah,
Karen, does that make sense?
Yeah, it does make sense. I'm just
so we'll talk
in the treatment and then the follow-up, and so I just don't know.
You need to know what your rate is, because you have a relatively small business. You don't have a lot of big numbers. And so your percentage of depressed people is going to be even smaller than your general consensus, your general population. Mm-hmm. So it's okay to have that. Like if you're going to get the depressed people treatment, that's got to be one ramp, because your other 2 ramps, excluding team, of course, your B and D or B and C or whatever you're doing, they've got to be robust. So we can talk.
Yeah, we need to.
Jeanette, what were you going to say?
So in the screening in RAMP C, at least HRSA defines the screening as like 4 different things. You know, the substance use, their viral loads, HIV viral loads, and number of partners. So substance abuse. So let's say they have a high sexual risk, but they don't use substances and their viral loads controlled. So then I would bring them down to the counseling RAMP D, correct?
Mm-hmm.
But then I would only need to intervene or on that one risk
Correct.
factor.
So that's where you as the clinician comes in with your own intelligence to say, you know, they live in a monastery. They're not sexually active. Not that that has anything to do with it. I'm just, you know, so I'm not going to, it makes sense to me that I've asked them and they say they're monogamous or they say they're asexual. So they have decided patient preference. I've counseled them. I've told them that, you know, the benefits, the risks, the evidence, and they've decided they don't want sexually transmitted infection risk testing because they're truly, you know, whatever. That's it. That when we get to the point where we're looking at data collection forms, I just label that an NA. You're not counting it against yourself that you didn't give them best care, but that particular care was not appropriate for that person. And so they're not applicable. It's not counting towards you. It's not counting against you. But that's something we'll get to once you kind of figure out what your qualifications are and what your screening is. Okay, you're going to qualify as high risk. You come down here. We're going to get you these things. Then we'll talk about, once we have that more specified, then we'll talk about who needs what.
Okay.
Does that make sense?
Yes.
Okay. Karen,
Yes.
what is your RAMP D? Tell me, no, I'm sorry. Tell me again what your RAMP C is.
My RAMP C is developing a care plan for a woman with mental health problem. And then RAMP D is follow-up screening once the intervention has begun. So those would be not everyone.
Right. So they're both great. They both could go under the concept of right care. You know, we identified you, and so we're going to get you the several things that I was just talking about with Jeanette. We're going to get you treatment. We're going to get you counseling. We're going to talk about self-management goals. We're going to get you follow-up. We're going to get you into all of those pieces could be considered quote unquote right care. So they could be in the same ramp.
Okay.
Does that make sense?
Yeah. Yeah.
Can you pull up your gap analysis? Let's just take a look at your gap analysis and see what else you have in there that might be something that we could think about. Now, Karen, okay, so you don't know, you screen your mamas using, is it the EPDS?
Yes.
And do you screen them once antenatally and once postpartum?
Yes.
Do you know when you screen them antenatally and postpartum?
Yes. We screen them on their first OB visit.
Uh-huh.
And we screen them again 2 weeks postpartum.
Okay. And what happens, and you don't know, do you know what the percentages of screening in the new OB visit is?
The percentage of screening in new OB is 100%.
Wow. And the 2 weeks postpartum is good also?
95.
And what happens if somebody screens positive at their new OB?
Then essentially that's where we leave them hanging. That's the big problem because number one, they won't take medicine because we're birth center and it's Colorado and it's the Western Slope. So we are really out there in the way of, they won't even take a Tums.
Yeah.
We don't have enough understanding of alternative medicine to really be able to provide good, solid, evidence-based options there. And there are no options in the community for counseling.
Okay, so let's hold off there a minute. Let's help Karen here. So Karen's screening really well, 100% and 95%. But she's screening at her new OB, but these people get lost. So couldn't your RAMP C be, yeah, but there's not many of them. You've got to find out how many there are.
Yeah, there's not, I mean, I can't go back and look at ICD-10 codes because I'm not privy to those. We have an outside biller and I don't have that information.
Yeah, but you need to talk to your IT people. It has nothing to do with billing. I mean, it could be through billing, but it also is just through diagnoses. So you need to, every one of you needs to get to be very friendly with your IT folks.
We don't have IT folks.
Yeah, but somebody must have sold you the system.
Yes, yes. Yeah, we've got the same billers. No, I think it's a different set of people that sold the system.
So Karen, you have a great idea of that follow-up with those new OBs. Who else was I talking to? Carrie, was it you? I think it's somebody who's doing depression right now. It's somebody who's doing depression and they're doing it in a Parkinson's clinic. And, you know, the standard PHQ-9, I can't remember if it's a 10 that they have to score or whatever, but she was finding that there were a lot of 6s and 7s. And so she dropped it down to, especially also because in Parkinson's, there's a lower threshold for depression. So she dropped hers down to, I think, a 7. I think she found evidence for a 7. And even though they aren't technically diagnosed with depression, she felt they were at risk and still doing some work with them.
Right. And
so do you have the EPDSs in your chart?
Do we have EPDSs in our chart? We
score?
We chart it as part of our nurses' notes or as our
that's the other thing, is to pull 20 charts and look at those EPDS scores and see what the range is.
Right.
Because you may be able to say, you know, I've got a lot of this not technically depressed, but I might need to be doing some work with those folks as well.
Right. And that definitely is a goal of this project, and I didn't know quite where to put that in, is we want to address those at higher risk for postpartum depression, antenatal anxiety, and so forth. So,
hey, I just had an idea, Karen.
Yes.
What about if you screened them everybody again at 28 weeks?
Okay.
I'm just throwing it out there. You know, you're screening them at the new OB, which is anywhere between 8 and 10 weeks, you know, for most people. What about if at their glucose test or at their ultrasound, maybe at 20 weeks, maybe at 20 weeks you screen them again, because you're going to catch a new batch of people who are now pregnant, struggling. So that would give you a follow-up to your new OBs. It would also give you a new screening ramp, and then you could take care of those folks in D.
Okay.
What do you think?
Yeah, I think that might be possible. A lot of our clients are transfers in after 20 weeks, but
well, anybody who's new to you should be screened.
Right. Yes, and they do, because they're considered UOB at that point. Yes.
Okay.
If they're transfer in. So yeah.
All right. Well, that's just one possibility that just popped into my head, so I wanted to share that with you. All right. So, does everybody have a sense of what they're going to be doing for their A, B, C, and D ramps?
I feel like I have too much stuff to do. Like maybe I chose too much.
Well, that we're going to work on. I mean, that we can always whittle down. That's better than not having enough. But
I literally have a tool for each individual person that's doing a task related to depression screening. Like I have a tool for our front office, a tool for our back office, and then multiple tools for each SBRITE. Like I have a tool for the screening, the brief intervention, brief treatment, and also treatment options, like what they choose.
Well, you want to remember that. So this is where my talk in terms of real life and school project comes in.
Yeah.
Real life is, it might be easier for your front desk if you give them a checklist. Can you make sure you do this, 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 and this on every patient? It's standardizing, right? Till that becomes, but you may not choose, because that might not be one of your processes. You're doing that could be part of your team that you talk about. That's going to be part of your team, that this section's going to do this section's. However, Carrie, that might be too much measuring of all those things.
Right.
You may, in your team, if we look at just your team ramp and you're doing huddles or meetings or something, and then what is your outcome that you want for your team?
So I did.
What have you found from doing your surveys? What sort of gaps does your team have?
Well, this is interesting. I thought that we didn't have all clinic meetings because I had no clue that we did, but apparently we do. But I didn't know about it. So I was like,
maybe
they got really defensive when I said that. I was like, oh, I had no clue. And I've been in this clinic the same amount of time other people have. So, so I think it's just improving, I think knowledge, and just in general, team satisfaction, like people identifying their team not just as the provider and the support partner, but as outside of that. So
Okay.
that's my measurement.
So what I'm going to send you to is the team steps, which has like a list of 5 or 8 categories: communication, leadership, vision, blah, blah, blah. And you might pick 1 or 2 of those. You might look at those and look at your team survey that you did and see what might I fill in. You might then have, while you're working with your team and you're building communication, doesn't mean you can't be doing all those little things with this team and that part of the team and that part of the team, but you're not going to measure all those things.
Right.
You're just trying to make their life better.
Yeah, I was thinking of measuring attendance to our all clinic meetings because I didn't even know they existed. So I'm pretty sure other people didn't. And then the other one would just be utilizing my staff satisfaction survey or my team satisfaction survey to measure that right now 40% of our clinic is a 3 and under for 3 of those measurements, and trying to improve that to, like less than 20% is 3 or under.
Okay. So the only thing that I'm going to warn you about again is make sure, I'm always hesitant about team satisfaction. If you have a great team satisfaction tool that's already in place and your team's already using it, your site's already using it, it's great to use that, because when we don't have to reinvent things, that's a beautiful thing. I only get anxious about team satisfaction or patient satisfaction or anybody's satisfaction because if you say to me, are you satisfied? Yes or no. I don't have a lot to go on. If you say, are you satisfied 1 to 5? And I say 2.7, I still don't have a lot to go on. So make sure it's not just satisfaction, but it really gets into the nitty gritty of what a team is and what the team feels as in terms of teamwork and team engagement. Make sure you get into that as well.
Okay.
Okay.
Yeah, I don't know if I'm measuring that because one of the measurements was that they feel comfortable talking about depression because that's a big thing. There's a big knowledge gap there. One of them is that they feel like they're part of the team because we've had this recent merge.
So those are team engagement issues. Those are great.
Is that what you're looking for?
Yep, that's what I'm looking for.
And then the third one is quality metrics, that they understand how that's measured so they know what they're actually being measured on.
Okay, good. So everybody's got sort of a framework. We know where we're going. Do you want to share team engagement surveys and patient engagement surveys? Or are you feeling like you know where you're going with the team?
Well, I have a question first, about you said the team steps, which I have. So there was somebody who did a SWOT analysis last year, and the team identified their weaknesses as communication, procrastination. Can I fit those into those categories of team steps? And then that would be my team engagement. So you're going to have to work towards those team engagements in your meetings, but those are the things that you will evaluate. If those were the gaps, those are, how a survey of some type or something that gives you the information of, how are we doing on whatever you said, communication, vision, et cetera, et cetera. Yeah, absolutely. Yeah, I'm not sure. I mean, I wouldn't mind seeing others' patient or team surveys. I feel like that's my weak point, how to engage the team.
Well, so what are some best strategies for team engagement? So I don't want to see anybody's, just throw it out there. Tell me what you've got for team engagement.
Team meetings, educational sessions. There's communication tools they can use to help communicate with each other. And then the huddles.
Okay, those are good. But what else? What engages a team?
So I shared to show you one. I know you don't want to see stuff, but this is what I'm doing with mine. I'm doing a naming contest for my quality improvement project. We're putting volunteers at our desk downstairs. I'm implementing a medical minute to try and, engage the providers to actually do something. We have a quality improvement wall that's going up that my Spirit at Work team is helping me design. And then at the end of my PDSA cycles, I'm going to have office parades, and the people that went the furthest in their measurements of the stuff that we're measuring for that goal, they're going to get, they get out of work a half an hour early card. And they'll make a big deal out of it. And I'm doing pop-up Fridays so that on Friday, every Friday, I'm going to have food and either lollipops or cake pops or something with pop in it, to just get people to be thinking about this.
What's Pop-Up Friday?
It's just something I made up. I'm going to find some dorky quality improvement, like it's hot, like it's hot in here or something like that, to play at 4:30 on Friday. And we're going to move so if you look at my screen, you can see that I have this wall here where I have the patient-centered medical home, and then I have all these cars which are representing my providers and the care teams, and then the train is our front office, and then the bus is the referral coordinators. Everybody has their own vehicle, and they have their goal that they're working towards. And so what they get towards, whoever gets closest gets the parade. And on Fridays, I'm going to be moving those, but I'm going to make a big deal out of it. Like that's all I'm doing is just putting fanfare around. I'm moving a car down the wall.
What she's doing, Jeanette, is she's having fun.
That's awesome.
Yes, she's having fun. Like, if you're going to have somebody come in and say, "This is what we need to do," they're not going to want to join you. If you're having a food party and you've got food and balloons and people are laughing, other people are going to trickle in and say, "What are they doing? I want to be part of that." So there is
like literally, I'm going to play some ridiculous song
that says this needs to be boring.
No,
it should be fun. It should be motivating. It should be encouraging. What is the vision that you want everybody on? What is the boat or the car or the bus that you want everybody on? So make it fun. You know, we had a student last term. Carrie, these are great. Thank you. Yeah. We had a student last term. I think she graduated last term, maybe 2 terms ago. She was involved in cardiac surgery. And she, oh my God, that woman, she had so many chocolate kisses and red wrappers that she was handing out to everybody. She had red buttons that people were wearing. She had red stickers on the flat. I mean, everything was red. Another person had their team. They called it team. What did she call it? They named their team. And same as Carrie, the team got to come up with a name for the project. And
that's where I got the idea from. It was Project Smile.
Yeah, everybody got to pick
and
that.
It was depression screening.
And then I have another person right now who's implementing, and breast cancer has something about lemons. And so she has a bowl of lemons on her front desk because, the lumps might feel like the skin of a lemon or something. So, there's all sorts of creative things that you can do. This is where you can have some fun. But so team engagement, the vehicle might be your meetings. But then within the meetings, you need to be doing team engagement, team building, morale building. That you got to be on that, because that's how you're going to get everybody up and functioning. And you have to be willing to put yourself out there in the team parade.
It's going to be great.
Okay, so let's talk about measures a little bit. We've talked about tools. Any tool that you're using, you have to the process has got to be, are they using the tool, right? So if I asked you, Karen, how do you know they're using the tool? So if you've got a shared decision-making tool, how are you going to know that Judy Butler, who's on Fridays in the clinic, is using the tool?
Hadn't thought that far ahead.
You gotta move that up there.
Yeah. I guess you could have the tool, if it's like a paper tool, scanned into the external document section of the EMR.
Yeah, you could do that. You could also just count it. You could collect them and count them.
Yeah, right.
Right? So for example, for you, if you're screening every new OB, postpartum, and 20-week, whatever your team decides, you're going to look at how many 20-weekers came in today and how many of these shared decision-making or screening tools got used. So again, it's the part over the whole, but you have got to think now, how am I going to measure this? Am I going to collect it? Are they going to document it? Are we going to scan it? Because it's a great thing if you have one of those tools that's sort of educational, you might want to send it home with your patient. That way, but the problem there is you're not collecting it. So how are you going to know? The goal is for not just you to fix your own patients, right? The goal is to fix a systemic problem. How are you going to take care of patients that thing is being done? Is everybody on an electronic health record?
Yes.
Yeah.
Does anybody or everybody have dot phrases or my phrases or something like that?
Yes.
Yeah.
So a beautiful thing, your providers are no different than your patients. They're probably actually worse than your patients.
Yeah.
And they want it to be easy and quick, right? So if I have to go in and was screened for depression using the EPDS and her score was 12 and I treated her for blah, 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 and I referred her to blah, blah, blah. Or if I could go click and it popped up on my screen that I screened her, all I had to fill in was what the number was. And it, like for my new OB, I have a new OB template in my phrases, and it's this big whole long thing with blanks in it. So all I have to do when my new OB comes in is I go click, it pops up, I fill in whether she wants to deliver at the birth center or TMC. I say yes, she wants genetic screening or no. It's all of the words are in there. So that's a thing that you can do. And if they use it, then we all know that if we didn't document it, we didn't do it, right? Like this is general theory.
Yes.
So if they document it, they used it. I mean, you can't, they might lie to you, but there's nothing you can do about that. Or you can physically have a piece of paper and you count them. So some way you've got to think about each of these steps. How are we going to measure this? So let's go over this again. If you have a tool, you have to measure if the tool's used. If you're using the tool, ask yourself, what is the purpose of using this tool? Am I screening somebody? So I want to find out if they need blah, 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 blah. Always if they need something, somewhere, am I getting them the care they need? Right?
Yes.
Now, for those of you who are using some sort of a screening and you're trying to track these people because you don't want to just give them a medication and send them on their merry way. You want them to come back for follow-up. You want to re-screen them, make sure that it's working, whatever, whatever. Many people have either in their EHR or they create a physical log, a case management log, where you're going to put, I'm trying to think, Adam, what you're doing again. Not HIV, that's Jeanette.
With naloxone.
Oh, right. So you have, but you're doing right care. You're
Correct.
not doing an expert. But you're still going to want to make sure that they're taken care of. So you have sort of that checklist of things that they have to get done. You may have a case management log for each of your C and your D. Because if you're saying they're high risk, now you got to get them this, 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 and this, and this. If it's one thing, you don't really need. If it's one thing and they're done, you don't need a log for it. But if it's sort of timing stuff, labs and testing and treatment and come back and that kind of thing, you want to make sure people aren't falling through the crack. It's that same idea of the hanging ramp.
Gotcha.
Okay. Yeah.
When we talk about so RAMP-D, since I'm going to use a combination, it seems, RAMP-D would be the right care tracking tool. I mean, there are some out there, but if I can tweak it and still call it a right care tool.
You're just going to make your own.
Okay, okay.
You're just going to say, these 5 things are what I consider, because you know what, Karen, or Jeanette, there could be 1,000 things that are going to be right care. So you have 8 weeks. So you are going to take, and this is the part, Carrie, that you're going to think about. You're going to take, I want to get these 3 things done. As long as you're not leaving any major gaping holes. I want to get them treated with medication, or they're going to do a self-management goal, or they're going to go to counselor, whatever they're going to do. I'm going to decide that these 3 things are my right care. Okay. And I'm going to make sure those 3 things get done. There's 1,000 things that need to get done, but I'm going to take this chunk.
Yep.
Make sense?
Yes, I've been struggling with that, like trying to find the exact tool that I want.
Make yours. And when we start talking, when you look in the, when you start to, first you have to figure out what your ramps, I'm just going to get my plug-in, guys, because I'm going to run out of batteries here. Once you get your pretty good idea of what A, B, C, and D are, and then you start to say, okay, what is my process? Meaning, what is the thing I'm going to do? Sometimes, does anybody have their measurement worksheet even started?
Yes, I do.
Carrie, hold on, because I want to see if anybody else does.
Yes, I do.
Yes.
I do.
Yeah, can you pull yours up?
Mm-hmm. Oh yeah, I forgot I had to.
Okay, because if you're looking at this, then you can understand what I mean by if I say go to the left or go to the right. So with Jeanette's, first of all, I'm not interested in the top half, that part that says increase, the blah, blah, blah. You do not have to have SMART goals. I got to get in there and change that. But that's just for my folks. I think everybody, all of us feel the same way, but I'm saying for my folks, you don't have to have that.
Which
What I
part?
want is the operational definition. So she's got the number of HIV team members trained over the number of HIV team members. Jeanette, let me ask, so you're doing participation, attendance, right?
Yes.
So how long is it going to take you to train them to use a form?
Not very long, probably.
So
It's
it's
fairly
probably, right. So you could just say, the problem with training is it's not engaging. So
Yeah,
how
I
about if
know,
we just say,
that's why I'm struggling.
how about if we just say attendance? The number
Where?
of team members who
Oh.
attend over the total number of team members who are supposed to attend.
Okay.
Does that work?
Yes.
So now she's saying her core thing is meetings. She needs to tell me how often those meetings are going to occur for her test of change. And she's going to get rid of that whole A top part thing, and she's just going to have the operational definition. So she knows she's going to hold team meetings of some shape or size or form. She can change it every week. I don't care.
So does this form represent 1 week?
No, this form is going to go through the whole 8 weeks. This is
So I
going to
need
be
to list all my interventions here.
just bear with me.
Okay, sorry.
So get rid of the whole upper half. That whole, can you type in it right now?
Yeah, sorry. So get rid of
that
this.
whole- Yep, get rid of that.
Okay.
Gone.
And then,
Now
and
put
then-
number of HIV team members attending. And then over total number of HIV team members. And again, if somebody's out sick, I don't expect them to come, right? Don't count that against yourself. If somebody's on vacation, they're not coming back from Aruba to go to your team meeting. Don't count that against yourself.
all right.
Now, what is it you're hoping to get with your team? Efficacy? Team efficacy is great. And so what she's got for her operational definition is the mean score on a Likert scale each week. So you're having a meeting every week?
I was hoping to. Is that too much or?
Nope. So go back to your HIV care team meetings and put weekly. Okay,
It's
so
not
she's,
necessarily education. I don't need to define that here.
nope. Your intervention, what I call the core intervention, the main thing that you're doing is every week you're going to have some type of a meeting, and she's purposely not going to define it. She may do something crazy one week, I don't know, but she's going to meet with those people every week. She may meet with them as a group, she may meet with them individually, she may do huddles, she may have parties, she may have a parade, but she's going to meet with them every week.
So it can be different things. Okay.
Yep. She's going to measure that process measure by the attendance, basically. And then she's got a great outcome measure there of efficacy. So get rid of the whole, increase the mean efficacy, just leave and get rid of the by 80%.
Okay.
No, just the by 80%.
Oh, I'm sorry.
Because I want to know that it's about efficacy.
Uh,
The whole after, it's okay. Get rid of from before June 22nd, 2018, that whole section. There you go. Okay, now your operational definition, you could say mean score, mean team efficacy score on a Likert scale. Now,
Here.
obviously, we don't want her team efficacy to go down. We kind of assume that we want it to go up. Perfect. Now you can get rid of that whole A thing. We don't even need that.
This here?
Yep, get rid of it.
Oh, okay.
Isn't this pretty?
Yeah.
Now, underneath your process measure and the operational definition, go down a couple spaces. Over under the process measure. Go down a couple spaces, yep. And now put baseline. Just the word baseline. Semicolon. And now go down again and put goal.
Okay.
Okay, so I want a baseline. So find out roughly how many people, what percent of people go to the last 3 meetings. If there are never any organized meetings, you're going to put irregular or something, you know, you can't really tell. And then it's hard for you to get a goal and you're going to have to just punt. I want you to put out your team efficacy survey right now and get baseline. What is the baseline right now? And then once you get a baseline, say your baseline is a score of 4 out of 5. I'm just making that up. I don't know what your thing is. But say it's a 4 out of 5, 80%. You're going to hope on most things you could go up by 20 to 30%. Not necessarily on team, but on everything else.
Okay.
So if you're running your team efficacy at, say it's 50%, maybe your goal is going to be 75%. But you need that baseline. Everything possible, everything possible. This is another one of those things that if I could speak in red letters, I would be speaking in red. Get a baseline for. So you're under your outcome measure, it's also going to say baseline and goal. Adam, did you say you've got one of these already started?
Well, I started it. Yep.
Can we peek at it? Thank
I'm
you,
free to show it
Jeanette,
to you
for
now.
sharing.
Yeah, I'll show it to you. What's that?
I was thanking Jeanette for sharing with us.
So while he's pulling that up, I'm not sure, like if I already did a team survey, but I'm not sure if I looked at this team efficacy. So I maybe need to write something up to make sure I made it.
It's the same idea, Jeanette. It's the same, doesn't matter what word you put in there. You need to have a baseline, whatever you decide their team needs. But that's where you're digging and finding out, what does my team really need?
Mm-hmm. Okay.
Okay, so Adam, let's look at your B. Can we look at B, Adam?
Sure.
So implement the patient survey and education handout, measure ability to teach back content. So the tool is what, Adam? Number of tools used over number of patients who's qualified. Perfect. But tell me, Adam, does the top half that says implement the patient survey and education handout, measure ability to teach back content of the education, is that the same as number of tools used over number of patients who qualified?
No.
So it's really implement whatever your tool is.
Okay.
Right?
Right. Yes, yes.
But your operational, the important thing is your operational definition is completely correct.
Okay.
Now, the other thing that I'll say to you is many people will say, well, we have 0%, their baseline is 0. We don't have any shared decision-making tools. I ask you to go into the chart and pull up 10 charts and look for any voice or handouts given, reviewed, patient decided to do whatever. Is there any language of shared decision-making or even a handout, which is the lowest form of a decision aid or a tool of some sort? Is there any baseline that you can gather? And then you set your goal.
Okay.
Okay, and so your outcome, you've got the wordage here. Increase the percentage of at-risk patients who are offered education about who is at risk for overdose, how to identify overdose, and how to use a naloxone atomizer. So actually, all those words that you had somewhere about the teach back,
Mm-hmm.
the outcome is if if you're implementing a tool to show them how to do it, and I don't know what your tool does, so you've got to ask yourself, what is the goal of my tool? But if you are doing something that they say, yes, I want to do that, and now they're going to do a teach back, the outcome is successful teach back.
Okay.
But again, what is the operational definition? How are you going to measure that? Are you going to have a dot phrase in the chart that you can measure teach back done?
Yeah, I've got to think about that.
Yeah, you know what I mean though? So, but
Yes,
it's
I
the
do.
same for all of you. Everybody's going to use some tool in their BRAMP. So your operational definition is going to be the number of tools used over the patients who qualified. The outcome, you got to look at your tool and say, it's a patient engagement ramp. So dear God, I hope you're engaging the patients. And what is my specific, what do I want from this tool? What do I want? Is it something that they can do a teach back on? Is it something that they are going to express understanding? Is there a Likert scale? Am I going to survey them? I mean, what are we going to do that is going to be the outcome of that tool? That I hope is the outcome of that tool. Because you want to know, are they using the tool? And then you want to know, was the tool successful? Did it engage them? Ask them.
I'm writing this down.
That's okay. Does that make sense to everybody?
Yes, it does.
Everybody is going to have a very similar type of outcome and process for their team and their patients. Your wording is going to be different, whatever you're looking for, but you're going to have a very similar A and B,
Okay.
at least in terms of how you measure it. And so you want to put baseline in there and you want to put goals. And tell Dr. Jollis I told you to.
Okay.
She and I are like left and right. No, I don't mean that we're opposites. We're like
Peas and
we're
carrots.
we're peas and carrots. We're peas and carrots. I haven't spoken to her on you today. That's unusual. All right. Anybody else have their measurement tool?
I
Even
do.
playing with it. Carrie, you froze. Oh, there she goes.
Yeah. Are you able to see
Can you
that?
show us either C or D, Carrie? Can you show us D? Because C, you're using a tool, so it's going to be the same thing again. But I'd love to see your D.
In terms of, I have the measurement up, but
That's what I'd love to see.
Yeah. Can you not see it?
I can't see the D. Can you just scroll up a little? Because the faces, everybody's face, there you go.
Okay.
Okay, so your process, checkout process will be completed in the room to facilitate follow-up scheduling and improve. Oh, Carrie, we're gonna work on your wordage.
Yeah, I know. After you said that, I was like, I need to go back and read this over
Do
again.
you have an operational definition, Carrie?
Well, at the bottom, I do 10 out of 20 charts will have follow-up visits scheduled in room, so I can look at where they were scheduled and see that.
Okay, so your C ramp is identifying people who are depressed. Is that correct?
My D ramp is right care, so they need to come back and get scheduled. They need to come back in.
Okay, so tell me what else is going to happen to these depressed people.
That's kind of, this is where it's hard for me to get back and forth because, okay, so the answer to your question is that they need to either have the option of watchful waiting, talk therapy, or medication.
Okay, so three options.
Yeah.
And they need to come back, right?
Yes,
And you probably need to rescreen them.
correct.
Okay, so let's just say those 5 things. So you've identified people in C. In D, what you need to do is you need to have a follow-up system. That's what it's going to call. See how you have over here? Follow-up visits. Just take out the whole visit thing and put follow-up. And a typical word for follow-up is that case management log that we talked about. Some way, electronically, on paper, I don't care, to follow these people to make sure they don't fall off the beat. So your thing that you're going to do is you're going to implement a tracking system. That's going to be your process.
Okay.
And then your outcome is going to be getting them 1, 2, 3, 4, 5, whatever those things are. Whatever you decide.
Okay. You're right.
Does that make sense?
Yes.
And
And I
then-
can easily do that. Well, so then my question would be, if I'm using a patient engagement tool to help make that decision, do I also measure if that tool is used, or I don't do that?
So
I
not
only
in
need to
D.
do that in-
In D,
okay.
that's going to be part of your aim. We'll talk about that in 1 second. So
Okay.
Carrie, get rid of all this checkout. Just cross that whole thing off. That whole D process. Yeah, that can just say follow-up. That's good. Follow-up, tracking, whatever you want to do. Get rid of that whole thing. Get rid of that. Now, your operational definition is going to be implement. You're going to implement the case. No, you're fine. You're fine. So it's going to be, if we have these people from C, so 5 people got identified. Let's just use the number 10 because it's so nice. 10 people in C got identified. So if you've got this case management log, what's going to happen? They have to get into the log, right? In order to make the log work, their names have to get in there.
Right.
So the
I would
operational
say-
definition.
Yeah.
Go ahead.
I was going to say
No,
you
go.
could use the diagnosis, the HCC code of, their depression screening was positive.
Okay, but there's my problem there. It's like telling me that IT is going to do something for you. That depends on your people, your teammates, giving them a diagnosis code.
Yes.
So I can tell you right now, if you looked up every person who's depressed, they might have issues about depression, and they might have treatment, and they might have this and that, and not all of them are going to have a diagnosis of depression.
Right.
Correct. Yeah.
So let's just take the people that you identify in RAMP-C, the number of positive screened patients that get in the logbook, because the process here is the logbook. So the number of positive screened patients in the logbook, entered into the logbook, over the total number of positive screened patients. The part over the whole. 10 people were identified as depressed. You want to make sure that all 10 of them get in that book. Now, that may seem like a really silly thing, but it's your way of not having to go into every single chart and look up every single person and see if they got all these things. You're going to have it in one place.
So this is a dumb question, but is a
No.
logbook like a physical book that I'm using?
It can be. Some people have that ability to do that in their computer.
How do you,
So-
okay.
So it's just however you want to do it. This is an easy way. This is the kind of the simple way. The problem with it, of course, is who's going to do it. And then once it gets up and rolling, how are we going to get rid of it? Because it's less than sustainable.
Yes.
Okay. And now your D is you're going to get them right care. So these people are going to be how are we going to define the people who get right care?
So is that what, gosh, that's the people that have all the check boxes checked, basically, right?
Right.
What you're asking.
So the number of patients who have right care they've gotten it, they've obtained it, over, yeah, keep going.
So the number of patients who are in the logbook, I guess I would say. Is that correct?
So it's just how, like in C, right? We screened everybody and then we said, okay, who's here? Or in B, you wanted to say how many people used the thing and then how many people that used the tool came out with the outcome you wanted. Here you're saying how many people got in the logbook, and then of those who got in the logbook, did they receive right care?
So then how do I make a baseline?
And that right care you can put as anything you want. Whatever is going to be right care in your institution is going to be different than right care in Karen's or Adam's or Jeanette's.
So in that scenario, because I don't have a logbook now, is my baseline just 0 out of 20 or 0? I don't know how.
It's 0 out of 20 for how many people were in the case log. But you
Right.
can look and see, you can get a baseline on how many people. Pull 10 charts. Try to find 10 people who are depressed. Try to see if you can get that either scrounging through the charts or doing the ICD-10 codes.
Now,
And-
I saw a question so I'm good friends with my IT people, and they've already been sending me informatics on like what my charts look like. So I could pull out how many patients I have that have either depression, and I've been putting depression screening
Which
in
is
since I
fine.
started.
It's nice if you can do your whole practice, but
I have that as well.
and so what you want to know is what are the number of people you want to pull those charts and you want to go through them and say, if this is my definition of right care, did they get what percent did they get? And that's your baseline.
I have that from my audit, my chart audit.
Great.
Okay.
That's absolutely right. That should have been, but not everybody makes all the connections. Sometimes you have to go back and do another chart audit
Okay.
because you've just now decided what's right care.
Okay.
So you might have known that you were going to do screening, but you might not have known exactly what your right care was.
But I have more. One of the other questions I have is like I have a lot of issues obviously with provider engagement in my clinic.
Everybody
So-
does, just so you know.
Right. Okay. So I guess I just was, and maybe other people already know the answer to this. It's a dumb question, probably won't ask anyways. For those of us that are having that issue, would we do our baseline data on the providers that are actually, never mind. I'm answering my question. Never mind. I already know the answer to that.
So I have a question, Dr. Butler, how you stated the my phrases, in the EHR.
Uh-huh.
So that you can make it easy for the really the adherence with this new process.
Right.
But then that isn't really an easy way to pull the data back out. But that's just kind of just what we have to do is just dig into that chart.
You're going to be doing chart audits every 3 days.
Okay, and then
But you don't have to
know
do
where to look.
every patient, Jeanette. You have to do a sample.
okay,
So you've got all HIV patients, is that correct?
yeah. Well, I care for others, but yeah, I would do only the HIVs. Yeah.
So, it depends. If you see 20 patients a day,
Mm-hmm.
so if Carrie's going to screen every one of her patients for depression and she sees 20 patients a day, she may take a sample of 10 or 12. If she's screening people if you're screening your HIV people for your risk assessment thing, and you only see 3 HIV patients a day, you're gonna audit every one of those charts.
Yeah.
Does that make sense?
Yes, and I guess the thing is, if you, like you said on the my phrase, if you know where it's supposed to be put, then that's where you look. You don't have to hunt around for it. Okay.
Right. And that is another thing, right? So it's easier for me to chart. If somebody says to me, I need you to chart right here. This is where I need you to chart. You are going to be able to find it. I'm going to know where to chart it. Ambiguity leads to people not remembering, they forget, they don't know how to do it. If you standardize, so enjoy this word, standardize, that makes things easier for you, the patients, the providers, everybody. It doesn't mean we have to be exactly the same.
So I guess the question I have on that one, because I brought that up and I have a lot of resistance to that. Do you have any,
Carrie,
is there
you know
anything you can say to say like, oh,
Well, you need to go. What do we do when we want to get someone to do what we want? What should be your first response for all of you?
well, I thought the evidence-based
That's what you need to do.
information
You
would
need to
be
go to
helping,
the
but
evidence.
it doesn't seem to help at all.
And that brings me to my second point. So every one of you has education in your ramps, right?
Yes,
How many
Yes.
smokers do you think know that they shouldn't be smoking?
right.
100%.
100%. They still smoke. So education is only going to get you so far. You have got to engage them. And Carrie, you're going to have an uphill battle, but
Yep.
you've got some great ideas. And I think that you find the other thing that I'll share with you of over the last few years, find your champions and celebrate them.
Yeah.
The smallest successes, the smallest person who's on board, who you overhear talking about your project or screening for this or that, or, talk to Adam because he's got this, you celebrate those people. Okay, the last thing I want to just jump into, we lost somebody. Who did we lose? Not Carrie. Who's the other person?
Karen said,
Karen.
I'm leaving as discussed earlier.
Oh, yes, she did tell me that. Thank you. I see it there. Thanks, Adam.
Sure.
You have to measure your aim and you have to measure your balancing measure. For your charter, everybody's supposed to put in a balancing measure for A, B, C, D, but we'll choose down to one. So you won't be measuring 4 balancing measures. We'll choose one. I mean, you can go ahead and measure 4 balancing measures if you want to, but I promise you don't want any more work. And then your aim, you have to look at what your aim is. Sometimes your aim is to increase exclusive breastfeeding rate. It's BAM, it's just that. Sometimes your aim is, I want to, and you look at what your, I want to effectively screen and treat all people for depression. So if we look at what is best practice, so your aim is kind of the big bow. Dr. Jolles describes it as the big bow that wraps everything up. If you're going to say, I'm going to do the best care for depression, that means you have to screen them. It means you have to treat them appropriately, right care. And the other thing that is best practice, of course, is some sort of engagement tool with your patients. So you could either say it's going to be the average of ramp C and D, or you could say it's the average of ramp B, C, and D. But you don't, the reason you just put operational definitions in and not all that wordage, because some of us are more concise than others, is you want to make sure you don't have operational definitions that are the same. So your operational definition, yes, Carrie, I am laughing. Your operational definition for your D ramp is right care just for that ramp, just for the people who get in there. But your overarching right care is that they got screened, which is ramp C, and that they got treated, which is ramp D. And then you could also include ramp B if you want, that they had a shared decision making or, you know, some type of engagement tool. So it really just depends what the thing is you guys are being given a lot of latitude. What is your choice? What do you want to say it is? Okay, we're down to 8 minutes, and I am leaving you in 8 minutes because I'm going to my class because I have been stuck in front of this computer for 4 days, for hours and hours, even more than you guys. What other questions do you have?
The example of the measurement worksheet had like patient-centered care. So they were using the words of, you know, the.
So you don't, you want to be thinking, thank you so much for bringing that up. That's a great point. You have to have an IOM aim in your title. If you are doing patient-centered, you have to show throughout your paper, when you write your paper, you're going to just thread it throughout, patient-centered. And you have to show, where are you doing patient-centered care? I mean, first of all, what is patient-centered care? And then where are you doing it? If you're saying it's effective care, you know, you're going to show that by the percentage of people who get right care. If they're getting the right care, that's effective care, right? So you have to look at, what does that IOM aim mean in IOM terms, and how am I showing it? So you don't get to pick timely and never show me anything about time. Not me, you know, everybody else. Okay, so that will be part of, you know, you'll have your framework, SBIRT or right care or whatever you're doing, but you'll also have that IOM aim that is really going to guide everything that you think all the way through your project. Okay? Mm-hmm. All right, I'm feeling like a Looney Tunes. I'm going to sign out. If you need me, Adam, you're with Dr. Jolles?
Yep, I have a phone meeting with her at 8 in the morning.
I mean, obviously all of you can call me as well, but it's usually really better to stay with your continuity faculty, or we mess you up. That's what we found, because I look at things from a slightly different perspective. So if you need me, you know how to get me. You can email me questions. You guys are all really doing super, super well. I see your projects coming together. If you don't see your projects coming together, then get a hold of us. All right?
Okay.
Thank you so much.
And I will send this to all of you. Thank you so much for all participation.
Thank you.
Have a great day, everybody.
Thank you.
Bye.
Thank you. Bye.
Bye-bye.